Okay, today we are going to learn about kind of emergency part of OHS, emergency part of infertility, which actually rarely happens in infertility. But this this syndrome, which we are going to discuss, is a very difficult entity to diagnose unless you know about it, because it happens only with infertility treatment, nowhere else it happens. So people who are associated with infertile couples, means the gynecologists, whoever is the sisters in the infertility treatment, everyone should be aware of such a syndrome which is unique to infertility. And it has a wide range of presentations, but very few of them become fatal and leads to death unless you identify them, treat, prevent, and do justice to patients. So this syndrome which we are going to discuss is called ovarian hyperstimulation syndrome. So we are going to So we are going to discuss about etiology, incidence, pathogenesis, primary and secondary prevention, and management. And if I get time, I'll just discuss a few cases which were there in RBMO online. I'll just try to discuss that also. How secondary OHSS with pregnancy was managed. Okay, so let's go into the topic OHSS. So it's a exaggerated response to ovulation therapy. It happens with oral ovulations also, but the risk is higher with gonadotropins because that is or the gonadotropins are direct dose pump of gonadotropin into the circulation, which directly target the oocytes and increase in estrogen. So clinicians who prescribe ovulation-inducing agents must be prepared to recognize and manage OHSS, right? So we all fall under this category. So OHSS is a very self-limiting disorder. Majority of time, majority are self-limited, usually resolve spontaneously within few days, but persist longer periods. In particularly when pregnancy happens. If pregnancy happens with OHSS or OHSS is mainly the OHSS is caused by pregnancy, it stays for longer duration. This is a broad spectrum clinic with very broad spectrum disease with a lot of clinical manifestations ranging from mild to critical illness, right? So, what are the major features of OHSS? It's characterized by ovarian enlargement due to multiple ovarian cysts, and acute fluid shift will happen. The main pathogenesis happens due to third space loss, fluid shift in the arteries. Okay, so the complications are ascites, hemoconcentration, hypovolemia, electrical difference. All this is due to because the intravascular volume, intravascular blood is extravasated in the third space, so causes all these things, right? So why should we know? Why should you know about OHSS? Because the prevalence of therapy employing ART is increasing. All physicians dealing with females in reproductive age should be familiar with OHSS. Its causes, its consequences, everyone should learn how to manage OHSS. If you're sitting in periphery, wherever you are, you should know how to manage a OHSS case. And mainly should understand the severity of OHSS, right? So the grading of OHSS, the incidence of OHSS, you can say, the mild forms are 8 to 23% of ART cycles. Moderate comes to 1 to 7%. The severe forms are 0.25%. Right? So the frequency of OHSS may increase if the number of follicles are very high that we know. We just go into it deeper. And mainly, as I've said, the gonadotropin agonists and gonadotropins. If it's an agonist protocol, the OHSS incidence is much more higher because we give HCG as a trigger. We don't give agonist triggers in an agonist protocol because it doesn't work. So the main thing is the E2. If the E2 is high, and if the agonist protocol we have given a direct HCG trigger, the incidence of OHSS is much more higher. But women who are childbearing age only will be affected by OHSS. So, what is the pathophysiology? What happens in OHSS? The hallmark of OHSS is increased capillary permeability, resulting in the fluid shift from intravascular space to a third space loss. This occurs when HCG is very much higher in your blood. So, what is the main culprit? What is the damaging factor in which creates OHSS? This is vascular endothelial growth factor is a major mediator to the OHSS. The VEGF serum levels increase. HCG triggers VEGF. In turn, HCG is the main causating thing which causes OHSS. The VEGF expression is increased. VEGF receptors are also significantly increased in response to HCG. So what happens if this VEGF is increased? This creates gap junctions in the arteries. So the extravasation of the fluid will happen. So how why they came to this conclusion is the recombinant VEGF produces effects similar to OHSS that can be reversed by specific anti-sera. That is how they got to know that this is the main culprit. So this vascular endothelial growth factor is a main culprit which causes this OHSS. So our target is vascular endothelial growth factor now, either to prevent. What should we prevent? We should prevent the formation of VEGF. We should try to curtail the amount of VEGS happens, that is secondary prevention. We should completely block the VEGS activity by decreasing the effect of HCG, that is our treatment. So our treatment rotates around this, right? I'll just show you a flow chart which shows the pathogenesis of OHSS. It is little dry to listen, but it is very important to understand the pathogenesis because when you are sitting in your OPD, you should know how this happens and how to counter this OHSS situation, right? So see here, this because HCG has a long half-life than an agonist, so HCG stays in blood almost for 7 days actually. So this HCG, which is exogenous, means what we give as a trigger is an exogenous HCG. And endogenous HCG, when there is multiple gestation happens, when there is molar pregnancy, when there is uh, majority with these two, multiple pregnancy and with molar pregnancy, elevate with normal pregnancy when the endogenous HCG is very high. This targets acts on the follicles. These follicles, per follicle, if there are more follicles, there is more secretion of VEGF. So per follicle, VEGF will increase. So what does this VEGF does? This VEGF acts on the vessel, increases the gap junctions, and increases the vascular permeability, and the fluid will go into the third space. So what will happen if the fluid goes into the third space? The hemo concentration, blood will become thick. So what happens if blood will become thick? If it becomes thick, there is no oxygen perfusion properly to the major organs. What are the major organs? The first affected organ is kidney. Patient will go into renal failure. So if the kidney is affected, automatically the brain is affected, heart is affected, and it lands into a multi-organ dysfunction. The first targeted organ is kidney. So first attack happens, and if this becomes fulminant, the first thing happens is anuria. There is no urine output. So if the pathophysiology is like that, the blood vessel the blood from the vessel, the plasma from the vessel is extravasated into the third space. So this is the major pathogenesis of OHSS. Now this, according to the ASRM 2024 guidelines, they actually divided the risk factors in the form of baseline risk factors during ovarian stimulation. So coming to the baseline risk factors, the PCOS it stands at the top. The PCOS patients are at risk of OHSS. So if you touch a PCO patient, your brain should always think about OHSS before doing anything. Even you are doing an ovulation induction, simple ovulation induction, also you're that chance, because there are multiple follicles. Whatever you do, it hits multiple follicles. So when you're handling a PCOS patient, even with a basic ovulation induction, OHSS should be in your mind. So previous OHSs, obviously they are very, very high risk. The AFC greater than 24, if the follicles are more than 24 and both the ovaries together, that they are very high risk of OHSs. AMH greater than 3.4 nanogram per ml. There are multiple studies, one for 3.8, 4, 6, but this is ASRM 2024 guidelines. It says AMH level more than 3.4 nanogram per ml, they're very high risk of OHSs. So coming to the risk factors during ovarian stimulation. So this is before that. These are the baseline risk factors. And there are two more things which I should mention. Age, lesser age, younger age people are more risk, and low BMI. Low BMI. These two factors I didn't mention it here because the recent ASRM studies says that they have no much different. They're not doesn't come under very high risk. Only these four comes under very high risk. So risk factors during ovarian stimulation, more than 17 follicles over 10 at trigger, and elevated estradiol 3500. This also there are many different consensus. Some says 3000, some says 5000, some says 6000, but 3500, this is the ASRM guideline. So greater than 50 retrieved oocytes. If we retrieve more than 50 oocytes, the risk of OHS is still higher. So coming to the risk stratification of OHSS, which is high risk, which is moderate risk. The AMH and AFC, the AIM, as I've already said, is 3.4 AMH and AFC greater than 24 high risk. E2 on HCG trigger day. On the trigger day, the risk, if the E2 is more than 3500, it is high risk. BMI is less than 18.5, very low BMI, still high risk. The follicle count, if there, I've already mentioned this, greater than 17 follicles, greater than 10 high risk on trigger day. PCO is strongly associated with OHSS, very high risk. Age, younger age correlates with higher sensitivity. It is moderate risk. Okay, total gonadotropin also moderate risk. If you give a lot of gonadotropin, lot of OHSS, that has the study says many studies counter, many studies say pro. So we consider it as moderate risk. Okay. So classification, how do we classify OHSS? It's early onset OHSS and late onset OHSS. Early onset OHSS is 4 to 7 days, up to 9 days you can take for two, at least below 9 days if the OHSS happens, we consider it as early OHSS. After 9 days, if it happens, it is considered late OHSS. Why this late OHSS happens? Because late OHSS happens because of pregnancy. Pregnancy also pumps HCG inside the blood and it causes OHSS, which is much difficult one to manage. So now we go into the OHSS according to the ASAM guidelines. Is also the GTG guidelines 2016, they're all similar. In the mild features, abdominal distension, discomfort, vomiting, ovarian is 5 to 12 centimeters. No much laboratory alterations are there. In the moderate, mild features are there. There is ultrasound evidence of ascites and hematocrit greater than 41%, WBC greater than 15,000, and hypoalbuminemia and LFTs. Okay. When it comes to severe, all the moderate features will be there. Clinical ascites, hydrothorax, severe dyspnea, and oliguria. If oliguria sets in, it is severe, right? So we have to monitor the urine output for patients with which we have suspicion for OHSS. And hematocrit is 41 itself, moderate OHSS. If it's 55 means there is lot of third space loss, so it is much more a problem. And WBC is much more higher. It is because of the hemoconcentration also. So 25,000. Creatinine clearance is less than 50. We usually don't measure it. The creatinine is more than 1.6. So these features should be kept in mind, which is now coming to The critical OHS, in severe OHS, all other features like intractable vomiting, tense ascites, rapid weight gain, 1 kg in 24 hours. A lot of rapid weight gain will be there. Syncope, venous thrombosis, which is very important thing to be managed in OHSS. When you have suspicion of OHSS, you have to think about this venous thrombosis because there is lot of hemoconcentration and changes of clotting factors will happen. So this should be kept in mind. With the critical OHSS, acute renal failure, pericardial effusion, massive hydrothorax, arterial embolism, all the fulminant changes will happen. So now coming to the prognosis. So what are the prognosis, like prognostic factors, like prognosis? How do we define it? In mild, moderate, excellent prognosis, severe cases, morbidity is clinically significant, fatalities do occur but rare. However, the prognosis is optimistic only. If it is severe, it's okay. They can revive back. So, but the fulminant OHSS is very difficult to manage. Majority of them will be majority are fatal. Death happens when there is hypovolemic shock, electrolyte imbalance, hemorrhage, and thromboembolisms. Right? Fatality rates are very rare, 1 per 4 lakh and 5 lakh. Okay. So now the first thing is prevention is always better than treating or cure. So we come to primary prevention. So what shall we do? So we these are the 4 5 things which we do to prevent OHSS. We reduce gonadotropins, which has a which actually come under moderate risk. GnRH antagonist protocols will use avoidance of HCG and LPS. If we do a test, so we'll go into detail, right? In vitro maturation is a new thing which people do for PCO patients and insulin sensitizing agents. So, how do we reduce the exposure to gonadotropin, especially when you're treating a PCO cycle? So, reduce the dose of gonadotropin. Start with low dose step up protocols. Start with 50, 50 to 75, 70 to 175 to 150. Like to increase the dose step up protocols. And if it's an IVF cycle, you exposure a lot of FSH, don't pump a lot of FSH. Start with basic doses according to the BMI and age. Preferably mild stimulation protocols we should use. So if you once C2 reaches 250 or 300, several follicles are there. So you decrease the gonadotropin dose, which is very controversial, but I just kept it here too. There's such thing which happens. Decrease in the gonadotropin dose has problems with outcome of oocytes and retrieval of oocytes. But there is a chance of decrease in OHS, but actually we treat the patient to get more oocytes. If we keep on decreasing the gonadotropin, chance of retrieval will come down. So it is little controversial. So yes, this is the best thing, the GnRH antagonist protocol. This is the best thing happened, actually best thing discovered for a patient with PCOS to prevent the risk of OHSS and to give a safe and safe baby, safe embryo and safe life actually. Because previously when the antagonist protocol was not there, when agonist protocol was only there, the risk of OHSS was damn high. Actually, the infertility treatment was much more difficult because the death because of OHSS was such very high when initially when there was no antagonist protocol. So the differential action of GnRH antagonists at both pituitary and ovarian receptors suggests that antagonist suppressed cycles might result in lower incidence of OHSS. Other advantages, there is low lack of flare effect, no accompanied menopausal like symptoms, no refractory period, reduced risk of cyst formation, shorter treatment cycle, reduced FSH consumption. These are also the additional advantages of antagonist protocol. So why this is important? Because if we use an antagonist protocol for LS suppression, we can give an agonist trigger. An agonist trigger has a shorter half-life, so the chance of OHSS is less. If the persistence of the LH is much more higher in the blood, the chance of OHSS is much more higher. That is the problem with HCG. But with the agonist trigger, the if agonist has a peak threshold and it sharply falls down. So with the agonist trigger can be given in an antagonist protocol. So that is why this antagonist protocol is a boon for PCOS patients to prevent OHSS and to get an embryo. So this is very important. So this is avoidance of HCG for LPS. This happens in a fresh transfer cycles. If you are planning for a fresh transfer cycle and if you want to give HCG for a luteal phase support, then again you are increasing your pumping HCG with pregnancy. Both will actually increase the development of EGF and increase the chance of OHSS. The result of lowered luteal phase defect is result of lowered endogenous LH release in a negative feedback from supraphysiological levels of E2 and P. Based on currently available evidence, it is recommended LPS in GnRH analog suppressed cycle should be provided with only progesterone or with supplemental estrogen also rather than for HCG. So if you want to support LPS, you give a progesterone and an estrogen than giving HCG. Then from the corpus luteum, you don't touch that. So again, you by you land up in OHSS than giving a proper luteal phase support. So this is one more thing, in vitro maturation, which is actually what happens in vitro maturation is we'll take off the follicle when it is we'll retrieve we do a worm pickup when the follicle is 12 to 14 only, because in the GB stage itself we retrieve the follicles and we'll put it in a medium in the lab and we'll make the follicle mature from GB to M2 in the lab. So that the exposure of gonadotropins, the amount of estrogen in the blood are decreased, which we never done IVM. I think OASIS have done many IVMs with the average success rate. The take-home baby rate is not much with IVM cycles. So many centers didn't haven't adopted IVM till now. Okay. So this is a very interesting topic. There are many studies on that. You can go back and see in the studies data. Okay. So insulin sensitizing agents, this is also a little controversial. Metformin till actually yesterday 2023 guidelines happened, the Monash University guidelines. We thought metformin was a amazing drug. Yes, it's an amazing drug to increase the sensitivity of the gonadotropin on a PCOS ovary, but it is not that amazing when it comes for the prevention of OHSS. That recent Monash guideline says that for prevention of OHSS, in an antagonist protocol, you need not give metformin because it has no much effect. So metformin has better effects for improving insulin sensitization, for improving the gonadotropin effect on the ovary, but not much to prevent OHSS, right? So coming to secondary prevention, yes, these things, once we start the gonadotropin stimulation, the secondary prevention comes in. So how do we secondary prevention of OHSS will go? So I'll just go one by one. All these things I have discussed inside. So I'll just go. First one is coasting. What is coasting? It's an interesting word, but not so much used nowadays because it has very poor effects. What is coasting actually means? Coasting means we withhold gonadotropin dose. Once see, like around day 7, day 8, we are seeing so many follicles came up. So much of E2 is pumped up. This estrogen is very, very high. So what we do is we stop gonadotropin. We don't give gonadotropin, and we give only the cetrorelix, just to not to stop the LHS, but we don't give gonadotropins. So this has previously they said it has good effect to prevent OHSS, but recently many studies says that coasting has no much effect in prevention of OHSS. It was a first line treatment, but there is no much support. So sometimes we also do that, but that actually decreases the number of oocytes retrieved, so we stop doing it. It is called coasting. Reduced dose of HCG. This is also controversial. If we trigger with 5,000, if we trigger with 10,000, anything, any difference is there. But it is like two edges of a sword. If we give more, if we don't give that adequate trigger, there is no maturation happens, and actually there is no point of doing the cycle. If you give lesser trigger to prevent OHSS, there is no this maturation won't happen many a time. So cycle cancellation is a possible drawback for low dose HCG. So no one uses this thing also. So this is a boon again. Cryopreservation. One is the antagonist protocol, and next important thing is the cryopreservation of all the embryos. This is like a boon because if you don't do transfer in that cycle, the chance of secondary OHSS is almost zero. So the amount of estrogen, the amount of VGS, everything will come down by all the hormones will come down if there is no corpus luteum, active corpus luteum. So cryopreservation of embryos is such a boon. It helps in, we can do a normal pickup, we can do OOSETs, we can do ICSI, freeze them, wait for the next cycle and transfer. And there is no difference in fresh ETs and frozen embryo transfer success. Actually, many suggest that frozen embryo cycle transfer success rate is much more higher. So these two things are very important in the prevention of OHSS. So as absent cycle cancellation by withholding HCG happens, despite the efficacy of method, most cycle cancellation has, what is the point if we cancel the cycle? So if we have given everything financially, we have burdened the patient and finally cancelling the cycle for OHS is no point. So you have to balance it, right? So alternative agents for triggering ovulation. This is an important thing. So one is antagonist protocol, freeze all, and coming to the triggers. Actually, we should come before that. Trigger. GnRH agonist trigger. This is the best thing to prevent OHS. I've already mentioned GnRH agonists have a shorter half-life. The peak, the LSH happens faster and it LH comes down faster. So the amount of estrogen in the blood and amount of VEGF stimulation happens in a very shorter time. So the chance of OHSS is reduced. So recombinant LH, this is also one of the things which the newer triggers. Triggering ovulation by RLH would closely mimic the natural LH search than which is H, because HCG is a what is surrogate of LH, it's not LH, right? So natural LH is much more natural because it won't be supernatural. So they tried LH, but the cost benefit ratio doesn't help. So recombinant LH is also not a good trigger right now at this point of, maybe the advances may happen in the future. So this is a recent thing. There's a recent study which is actually an ongoing RCT in 2025. Kisspeptin 54. This is Kisspeptins anyway we know already. It can also induce oocyte maturation with low OHSS rate. There are some studies. This is promise. Emerging RCTs were there on ongoing research, promising for very high risk cohorts, not yet standard, but this is the upcoming study. Kisspeptin trigger also helps in good retrieval of oocytes with decreased OHSs. Next, coming to the, once we have done the pickup, we retrieved oocytes. Now we have to prevent OHSs. This is what we do every day after the pickup. So actually the human albumin we have to, because human albumin increase the osmotic pressure of the blood, the plasma oncotic pressure, it increases. So all the third space will come into the bloodstream. So because human albumin is costly, we use hydroxyethyl starch, which is a cheaper and potentially safer alternative for albumin. This hydroxyethyl starch we use day in and day out in our post-operative wards, so that it helps in increasing the plasma oncotic pressure, so that third space loss is decreased, hematocrit is normal and increased, and the normal plasma volume is maintained in the blood. So the next important thing, cabergoline we use. This actually, there are some studies which we don't practice, and some studies say that pre-treatment, cabergoline pre-treatment before OI also reduces ovarian response to FSH by controlling LH levels, which is a potential prevention of OHSS in such cases, but we actually do not practice that. How cabergoline actually helps in preventing OHSS is it acts on the VEGF receptors implicated in vascular hypertrophy. It actually blocks VEGF, helps in blocking the VEGF receptors and VEGF receptor mediated action, so that it decreases OHSS and it decreases and prevents severe, and either it actually curbs the progression of OHSS from either moderate to severe or mild to moderate or severe to culminate. It tries to curb it. Okay. And calcium gluconate infusion. This is also we routinely use in our post-operative wards. Infusion with 10 ml of 10% calcium gluconate in 200 ml physiologic saline within 30 minutes of pickup. Ideally, day 1, day 2, day 3, at least 3 days is very effective as cabergoline in preventing OHSS. Severe OHSS, it decreases OHSS recurrent occurrence rates when used in high-risk patients. Okay, this is also helps in increasing the oncotic pressure of the blood and maintaining the plasma volume. So this is very important, right? And glucocorticoids and their derivatives, they also inhibit, they decrease the inflammatory mediators. And actually, glucocorticoids can be given before pickup also. Many a times, if the patient is complaining of severe abdominal pain before trigger, severe discomfort, we can actually give hydrocot around 100 mg IV before the trigger. Also, it decreases the inflammatory reaction, which usually happens during the uh, trigger, pre-trigger also. And aromatase inhibitors, see, this is also this how aromatase helps. Aromatase actually catalyzes the rate limiting step in the production of E2. So the amount of E2 is decreased. If the amount of E2 is reduced, the amount of VGS production is decreased. So the aromatase inhibitors also help in decreasing the OHSS. So now we have done primary prevention, we have done secondary prevention, still we got OHS. So how do we manage? So how the management starts with history. First, we have to ask what is the age, when the OHS started, to understand whether it's primary or secondary, how many number of, whether the ovulation induction happened, if happened, when the pickup happened, how many number of eggs, what was the E2 level, everything detail we have to take the history, and we have to examine the patient. Abdominal gut should be examined, urine output, pain, bloating, shortness of breath is any symptom, how patient is able to maintain oral fluids or not, we have to take a detailed history. So we have to examine as a vital signs, weight of body weight is very important. There's too much increase in the body weight in OHSs, abdominal gun at the umbilicus, and we have to observe for the ascites, pleural effusion. Any signs of venous thromboembolism should be observed. Don't forget that, because many we don't, it doesn't click in our mind unless we know it to observe. So how do we have to see the calf diameters also. The calf diameters should be measured, and the pelvic examination should be very gentle so that we don't, ovaries are already bulky, we don't cause any bleeding or chance of chance of
Utama. Tinta.
twisting. Ovarian torsion may happen because ovaries are
పడుకున్నాడు.
bulky. So minimize your pelvic assessments, right? And yes, hematocrit is very important. We have already told you that hematocrit should be measured to understand the thickness, I mean, hemoconcentration. So there are two kinds of management: outpatient management and inpatient management. The usually mild to moderate OHSS we can manage in outpatient basis. With severe OHSS, patient has to be admitted, right? So inpatient who are unable to, at outpatient management, there should not be any blood changes as mild to moderate, or moderate in just hematocrit change. Minimal changes are okay. If they are orally maintaining their hydration and there is no much discomfort or much abdominal distension, you can manage an outpatient basis. Inpatient, if they are not able to maintain the oral hydration, if there is much more hemoconcentration, severe abdominal distension, then they should be admitted. So, what are the kind of managements? What will we do to ease the symptoms of the patients with OHS? We do a paracentesis. There's a lot of fluid inside the abdomen, causes a lot of difficulty in movement, the abdomen, diaphragmatic movements. So we try to tap the ascites, means we try to put a catheter under ultrasound guidance. We can drain the fluids. Okay. So we can put a continuous drainage also, but the risk of infection is high. But we can fluid tap it and we can leave it. We should not completely empty the abdomen. Some fluid should be there. So the maximum fluid we have to drain it. So when there is severe abdominal distension, secondary to ascites, shortness of breath, and there is respiratory compromise because of severe intra-abdominal pressure, and there is a problem with the diaphragmatic movements, you have to tap it. And severe oliguria needs adequate replacement, then we have to, because sometimes abdominal pressure itself causes the decreased blood supply to the kidney. So even if we remove the ascites, that helps in improvement of renal circulation and renal perfusion. So at that point we have to add the ascites. Culdocentesis. Culdocentesis actually we frequently do when the patient has a lot of discomfort. We just put a needle inside the POD and we drain under USG guidance. That helps in patients with moderate to severe OHSs. And it actually is a, like kind of OPD procedure. It gives immediate comfort to the patient, and it helps in the resolution of severe OHSs also. Pleural tap usually, if the ascites is tapped time to time, there is no much pleural effusion happens. But if pleural effusion is there, we can go ahead with pleural tap also. This is fluid and electrolyte management is the heart of management of OHSS. So we should try to manage the patient with oral fluids. Additional IV hydration with a crystalloid solution, 100 to 150 ml per hour. Persistent intravascular volume depletion despite aggressive IV fluid hydration, we have to do albumin. We are trying to put a lot of fluid and it is going to third space. Then we have to add albumin so that if the oncotic pressure is maintained and the fluid gap junctions are closed and the intravascular volume is maintained, so the hydration improves. So albumin is actually stays in IV fluid crystalloid plus albumin is the cornerstone for the treatment of OHSS. We should not use diuretics much unless the intravascular volume is replaced because again it further depletes the intravascular volume.
Mm.
So pain relief we try to avoid NSIDs and with the antiplatelet properties just to prevent because in a fresh
പടുക്കുന്നില്ലേ
transfer
എന്നോട്
cycles,
ഉണ്ടാക്കി
someone just mute yourself. So with antiplatelet property should not be used because they may interfere with
അതുകൊണ്ട്
implantation and may also compromise renal function in women with severe OHSS. So preferably
അതുകൊണ്ട്
acetaminophen with the paracetamol or some tramadol we can give for pain relief. Nausea and vomiting should be managed. This third thing is thromboprophylaxis. You have to put a lomoil clavate heparin or a dalteparin sodium 500 units per day at least for 1 to 2 weeks till the effect till the cycle comes till the patient comes to normalcy. Patient should be on thromboembolic prophylaxis. Okay. So, like, how do we monitor the patient once the patient is admitted? What all things we should see in OHSS? Weight and urine specific gravity. Weight you should see. Vital signs, urine output and fluid balance should be recorded. Urine output minimum of 30 ml
മതിയോ
per hour,
കേട്ടോ
so that so that there is no renal compromise. Adequate hydration, cardiorespiratory status, degree of ascites, we have to see the abdominal girth, any signs of thromboembolism. Every day we have to monitor all these things. HB, hematocrit, creatinine, electrolytes, and albumin should be documented almost every day. So a weekly measurement of liver enzymes also should be done. So complications such as renal failure, thromboembolism, pericardial effusion, ARDS also happens. Then we have to take a multidisciplinary team into consideration and we have to manage it in ICU settings. So this is about OHSS. So this phrase I like in the quest for creation, the ovary reminds us that balance is the true essence of fertility. So we have to balance the oocyte retrieval with the OHSS. That is the cornerstone of the treatment of OHSS. So I just share you two cases which were published in RBMO online. Okay, I just So they have started a random start ovarian stimulation for a donor cycle. This is in an RBMO article. This actually happened in Austria. Okay. So this case I just want to discuss because they managed a secondary OHSS with pregnancy, right? So this case is a 30-year-old woman, fifth oocyte donation after four uneventful cycles. She was herself a healthcare professional. Ovarian stimulation in the luteal phase in the day 19 of her cycle started with an antagonist protocol. Right. So on day 14 of ovarian stimulation, gonadotropin stimulation was stopped because they incidentally discovered a beta positive, serum positive beta HCG. So leading to cancellation of planned ovarian trigger and oocyte retrieval. So they haven't, day 14, they have seen beta HCG is positive, so they haven't given the trigger and they want to curtail the oocyte retrieval. So they But how to decrease the raised estrogen? They 0.25 mg ganirelix daily was continued. They were giving that because of an antagonist cycle and they continued for 11 days. Initially, patient complained mild abdominal discomfort. USG revealed huge, large ovaries, 9 to 11 mm, almost 16 to 20 mm size, 40 follicles were there, and free fluid was there in POD. So the endometrium was homogeneous, hyperechogenic thickness, no GSAC was seen. Serum HCG and progesterone are 255 and 60, very early pregnancy. So they thought, okay, we'll manage it outpatient basis. So advised initially, if there are any symptoms, we'll see. So initially, but due to progressive symptoms, including abdominal distension, dyspnea, the patient was hospitalized 1 week later. They have seen elevated serum creatinine, hemo concentration was there, hypokalemia, hyponatremia, hypoproteinemia, everything was there, kind of severe OHSS. Then they treated supportive care, thromboprophylaxis, antiemetic and analgesic medication, intravenous fluid therapy, human albumin. What all the treatments of OHSS they handled. They performed culdocentesis on day 5 of hospitalization to ease the symptoms. Almost 4 times they performed culdocentesis. Regular inpatient monitoring confirmed a vital pregnancy. Now they did a scan again. They've seen a sac. Now the pregnancy is they could see a sac. But patient they thought of terminating it, but patient wants to keep the pregnancy. So the patient condition almost 16 days of hospitalization. They just given a symptomatic treatment. After 16 days of hospitalization, subjective improvement of OHSS symptoms, regular diuresis, normalization of laboratory findings, and reduction in the abdominal girth leading to discharge from the hospital happened. Thus far, they said till they published it before the delivery itself, they said progress pregnancy was fine till now. This is one more patient. It's a PCO. Okay, 38-year-old PCO already gravid for para one, second IVF cycle, 6 unsuccessful OA cycles. This followed of an alpha, which is gonalad, started on the 40th day of LMP. Kind of random start protocol. So initially everything was normal HCG, FSH, progesterone, LH concentration on day before the start of ovarian was 0.2, 5.6, 0.26, 56 and 17.2. So all are in the normal range considered basal. So they have no suspicion of pregnancy till now. So everything was normal. On day 7 of stimulation, serum progesterone was 2.11, day 7, and increased to 4.07 on day 9 and day 10 of stimulation respectively. So progesterone was continuously increasing. So due to hyper response, there are so many 19 follicles are seen. Serum progesterone was elevated and agonist trigger was given and 22 oocytes were retrieved. 5 days after retrieval, 5 days after the pickup, patient presented with abdominal distension. Transvaginal, yes, I've seen large ovaries. Endometrium was hyperechoic and homogeneous. Thickness is 16.9 mm. So outpatient management is recommended, but due to progressive symptoms, again they were admitted. Is hemo concentration, right? Hematocrit was normal still. So hyponatremia was there, mildly elevated white blood count, elevated river enzymes were seen, slowly going into severe OHSS. So supportive care they have given. Culdocentesis was performed twice, and on day three, the beta when the patient is admitted on day three, the beta HCG was 132. Patient condition was stabilized on day 12, subjective improvement, symptoms, and normalization of laboratory findings. Outpatient visits confirmed a healthy early pregnancy. The patient delivered a healthy infant, with 3 kgs at 40 weeks of gestation. So, thing is, I want to know this point. As the release of vasoactive molecules by the gravid corpus luteum drops from fifth week of pregnancy, despite increasing HCG concentration. So, means the VEGF production falls down after fifth week of pregnancy. So, once if the patient is pregnant, if you're managing a secondary OHSS, you can observe the patient till fifth week because after that the VEGF production is decreased, so patient settles on itself. So this thing, despite increasing HCG concentration, spontaneous resolution of OHSS was anticipated. So for secondary OHSS in pregnancy, it has to be continued patient monitoring. Patient should be very closely monitored till 5 weeks. Because after 5 weeks, the spontaneous resolution happens because even the how much HG is pumped, VEGF won't react. So this is the point I want you to remember. Okay. Thank you. I hope it is interesting.